Good afternoon, dear friends, dear colleagues. We're happy to welcome you at the Eurasian Congress of Internal Medicine. And all of us today are meeting in hall number 4 to speak about urgent issues of GIT pathologies. The program is very interesting for specialists of different areas, therapists, family doctors, and gastroenterologists. Today, we will have leading experts of our country, and we will discuss the issues of liver diseases, intestine pathologies, microbiota. We will speak about comorbidity and the contribution of the gastroenterologists in managing such patients. The first presentation, which is called A New Paradigm of Pathogenesis of GIT Diseases, will be made by the leading gastroenterologist of our country, member of the Academy of Medical Sciences, Doctor of Medicine, Igor Maev. So, good afternoon, dear colleagues. The theme of my presentation is a new paradigm of the pathogenesis of GIT diseases. So I will mainly speak about the syndrome of increased epithelial permeability. Recently, the first national consensus was published to analyze the pathological and clinical aspects of this syndrome as one of the basic mechanisms of the pathology development. This syndrome is associated with the proteins and the increase of paracellular permeability. This syndrome is considered as the major pathological link in forming organic pathology of GIT, because through the distorted contacts, the cavity of the GIT, the deep areas of the wall get bacteria and toxins, and they cause inflammation. And the intensity of inflammation depends on very many factors. For example, the factor of aggression that is translocated into the structures. And if inflammation is of low intensity, we will see the distortion of thick contacts, the distortion of functions, and we may see such diseases as dysfunctional dyspepsia, functional constipation, functional diarrhea, so functional diseases mainly. If the inflammation is of a high intensity, we will see damages on micro and micro levels, and we will see organic pathologies, GERD, chronic gastritis, duodenum diseases, enteritis, ulcerative colitis, and others. Of course, this phenomenon has been studied for a long period of time, but in the recent years have been characterized by the very good systematization of those data that had been collected. And as an illustration, I would like to show this slide of 2017. This is meta-analysis of polygenome associative trials. And you see the results, you see the translocation of ions and the permeability. This is transmission electronic gastroscopy. You see that the diameter of intercell spaces is widened. You see the morphological manifestations of those changes. They are observed with this syndrome. This is one more trial. transmission electronic microscopy was used for non-erosive GERD and in the control group. With no, in case of ERD, you see the results, you see the results compared with the control group. One more trial studied the barrier function of esophagus and expression of proteins in healthy people and in GRD people. In GRD, Claudin 1 and Claudin 4 were reduced in patients with GRD. And to sum it up, I would like to cite what has been written in this consensus document on epithelial permeability. And one of the links of GRD is the phenomenon of a higher epithelial permeability. And it defines the clinical manifestations. The syndrome is associated with the non-erosive forms of diseases. The use of ribamypin opens new prospects because this drug has a unique mechanism of action aimed at removing the main factors of pathogenesis, including increased epithelial permeability. One more block of data related to the activity on the inflammatory process in the mucus of the stomach. That is the first the trial that was made in 1984. It was a pathological test. The staining was done with trypan blue, and it was shown that in chronic gastritis, we can see microscopic manifestations of the increased epithelial permeability. This is the paper of 1994 associated with the validization of the saccharose extraction test validation. Saccharose does not have an ability to cross epithelial barriers, and only when permeability is increased, it may be defined in urine. And it showed the high diagnostic value of this method in assessing the GIT pathologies. If there is a syndrome of increased epithelial permeability, you see sensitivity up to 84%, specificity 90%, so it is a very high diagnostic value of the test based on testing increased epithelial permeability. One more trial made later, this excretion of saccharose showed a very high efficiency and sensitivity. One more trial showed correlation between the data of this test and the size of the ulcic lesions. And one more slide that characterizes the main factor of aggression that happens in case of GIT disorders. This is Helicobacter pylori infection. It is known that cytoxin and urease of the organism may induce the organization of thick contacts of cells, and you see an activation para-1 kinase. In 1997, in a very widely known magazine, Helicobacter, a paper was published that showed that the successful eradication of Helicobacter helps regress the disorders in epithelium permeability approximately 4 weeks after treatment. At that moment when we see a very sure morphological response to the eradication therapy. The consensus also says that in accordance with pathological data, we have an expressed increase of epithelial permeability during ulcerative diseases. This is the mechanism of pathogenetic damages associated with the factors of aggression. And it was also shown that this acid suppression therapy may be combined with hepatoprotectors. So the syndrome of epithelium, increased epithelium permeability, and the inflammatory diseases of the bowels. We can see that there is a link between these two diseases. These are locking claudins. They affect the selective exchange in the GIT, and suppressing this expression violates the barrier functions of epithelium. Here you see that the consensus says that the presented data testify to the key role of the violation of the functional barriers. So whether it is a primary determined defect or a secondary defect against autoimmune changes, nevertheless, there is a reduction of contacts, and the restoration of this contact is very important for treating all GIT disorders. The syndrome of increased epithelial permeability is a function and the functional diseases of GIT. This correlation is very well studied, and in case of IBD, we see the reduction of occludins, claudin 1, and in functional dyspepsia, we also see the reduction of occludin expression. This data correlated with the symptoms, with the whole number of morphological changes, and testified to the importance of pathogenetic increased epithelial permeability. The consensus also said that, of course, the motorics is distorted in the SEEP, but it is a very important pathological mechanism due to the changed amount of eosinophils and mast cells. The least studied factor of epithelial permeability is again this thick contacts, accumulation of mast cells, which leads to the increase of visceral sensitivity. It distorts the motorics motion of the GIT. That's why the correction of the syndrome is very important. The same is characteristic of CR in IBD. It has the same importance for the IBD as well. And it has already been said in the previous slide, it's very important to correct such disorders with drugs. We have quite a new drug, rebamipid, that promotes reparation of thick contacts of cells. And that was demonstrated in very many clinical trials. This slide shows the trial that shows the use of rebapimid and PPIs. You see the expression of Claudin 3 and Claudin 4. And one more paper that demonstrated that combined therapy of PPIs and rebapimid in case of GERD helped reduce relapses of this pathology. And these are the data of the meta-analysis of 2018, 17 trials, over 2,000 patients, and the result, you see that leveling out of dyspepsia was much more expressed when rebamipid was used. This is one more paper, sub-analysis was conducted, and we saw a very good qualitative scale. Rebamipid really promotes regression of functional and organic dyspepsia, and you see the number. You see the average numbers were very high. Here I would like to thank you for your attention. I would like to stress that the syndrome of increased epitheliological permeability that we speak, which we call as a gastrointestinal pathology, this is one of the main universal pathogenetic mechanisms of forming organic and functional pathology in GIT. And it is to be studied, it is to be diagnosed, and it is to be corrected. And we have at least one drug which in vivo and in vitro demonstrated a very good curative effect for this correction. This is rebamipid. Thank you for your attention. Thank you, Igor Veniaminovich, for a brilliant presentation. And the main thing we have heard are the data about universal mechanisms, about the possible interests on the part of specialists of other areas that will join our discussion in the future. Let us follow our program. I would like to remind our participants that we have a chat and you can always ask your question. And of course, we will leave some time for discussion. And the next presentation will be made by me, Professor Bagulin from St. Petersburg. I will speak about IBD and the most key issues. We do not have much time. And the first problem, if of course the most actual issues of epidemiology of IBD. What is therapist supposed to know? Recently, we have had only a few papers where we see epidemiology, the incidence of IBD in Russia. And here, you see the data of different international organizations. They said that the incidence is high, but these are the white data that incidence of ulcer colitis is lower than in developed countries. And I think we can share our experience, and it will be of interest to doctors of different specialties. This is the northwestern center of BID. There is over 1,200 patients. 2/3 are patients with ulcer colitis, and 1/3 is Crohn's disease. This is the distribution by age with the ulcer colitis and Crohn's disease. You see gender. We have men and women in both diseases. The peak of the disease is on 30, 40 years of age, the most flourishing age of the patients. And all symptoms start to be manifested long before the disease is diagnosed. Also, here you see the severity of the disease also. Crohn's disease, ulcerative colitis, and the severe course is 20-25%. And the majority of patients are with severe, with moderate or mild disease. A few words about the efficacy of pharmacotherapy through the prism of evolution. We might say that despite the pharmacotherapy that is developing, only 50% of patients with ulcer colitis after the first years after the diagnosis have remission. The other 50 have recurrences and relapses. The situation will aggravate after 5 years. Only 20% of patients, the disease is controlled. As to surgical interventions, we might see the following today. Although the drug therapy is developing for Crohn's disease, but all patients with the Crohn's disease, 30-40% of them and 20-30 in ulcer colitis go through some surgical treatment. The second issue is diagnostics and differential diagnostics. I would like to draw your attention to the very famous algorithm where we have clear symptoms of ulcer colitis and Crohn's disease. But the diagnosis, all these diagnoses are made on the basis of an overall examination. But with all this, although we know these signs very well, that in ulcerative colitis we see we don't see such complications as fistulas and inflammatory infiltrates, but they are typical for the Crohn's disease. Nevertheless, in ulcer colitis, the period of verification of diagnosis is over 1 year, and in Crohn's disease, it's over 2 years. But a more detailed presentation, how quickly we can diagnose the case, is shown in only 10% of ulcer colitis. The diagnosis is verified for 4 years and less. And for 20%, we sometimes have to do it for 5, 6, and more years. In Crohn's disease, we can verify the disease for 4 years in only 60%. In all other cases, we will need a longer period of time for verification. And such moments as these or those complications. Look, in Crohn's disease, we have perianal Crohn's disease, strictures, fistulas, abscesses. It may indicate not only that it is a dangerous disease, but it may also show that when such complications appear, that may be an instrument for differentiated diagnostics, and that can be other than intestinal manifestations. And the same patient may have several manifestations, arthropathy, stomatitis, and in ulcer colitis, it's about 20%. This is an example how the relapse manifests itself. You see the manifestation. This is other than intestinal manifestation, for example, peripheral arthropathy, and this patient, the diagnosis of a segmentary lesion was set. As to treatment and prevention of IBD, I would like to say that in 2020, we received new recommendations from the healthcare ministry for the treatment of ulcerative colitis and Crohn's disease. They are echoing, they are similar to European recommendations. And the most things are the most important. First of all, the duration of the maintenance therapy for ulcerative colitis patients. Patients with ulcerative colitis are to remain on the maintenance therapy for the entire life. And the main drugs are mesalazine, that is the main drug. In case of Crohn's disease, the recent recommendation of the European Society of IBD and Russian recommendation repeated the thesis that the use of 5-ASA are not effective for the Crohn's disease. But in accordance with our Crohn's disease register, we have 500 people. Over half of these patients receive 5-ACA drugs. We should understand for what purpose these drugs, 5-ACA, are prescribed, but for the maintenance therapy, these drugs, in accordance with the recommendations, are not effective. A few words about biological therapy. Now we see a boom of clinical trials in biological drugs. And here I would like to show the opinion of those authors of Nordic Register 3 done by Denmark, Norway, and Sweden. You see the frequency of surgical interventions from 2010-2016, we see that the biological therapy is used more and more frequently, but the frequency of surgical interventions hasn't changed for ulcerative colitis, and the same can be said about the Crohn's disease, although the biological therapy is now used at an earlier stage. So we say again and again that it is necessary to search for effective pharmacotherapy to prevent relapses, recurrences, and induce remission. As to prevention, you see the result of meta-analysis on patients with ulcerative colitis on the prevention of colorectal cancer. And we are to remind again and again that IBD is a pre-cancer disease, and the duration of the anamnesis from 10 to 20 to 30 years will promote the growth of colorectal cancer cases. You see As to the Crohn disease, there have been a lot of discussions. They said that there is no colorectal cancer after Crohn disease. But here we see a representative meta-analysis saying that after 10 years of Crohn disease, 6 or 8 patients develop colorectal cancer. We shouldn't forget that the small intestine disease is also developed very frequently, and it may lead to the cancer diseases. What new do we know? Today we speak about the necessity of making colonoscopy for patients to monitor and prevent for early diagnostics of colorectal cancer. And here you see the the group of patients which have to undergo colonoscopy every year. But if patients have a mild, moderate diseases, if they are not relatives to those patients whom adenocarcinoma was diagnosed before 50, then there is no need to make colonoscopy every year. And that's what we see in the guidelines of our foreign colleagues. I would like also to show the thesis that 5 ASKC diseases, they have a chemoprophylactic effect on IBD in patients. No, so here you see the dose of mesalazine that is to be used. And it is also very important to say a few words about the COVID-19 situation. What lessons have we learned? Our university, like other federal institutions, would profiled several times because of COVID, and we have our own experience. A group of authors headed by Professor Mai, by Professor Travkina, participated in compiling these recommendations of the first and the second version in the conditions of COVID-19. And the positions of IBD patients in the context of pandemic were presented in one of the sections. I wanted to dwell on most important positions that are being discussed. Patients with IBD have a similar risk, not a higher risk of being infected as compared with the general population, and the indicators of lethality from COVID-19 are comparable. Nevertheless, there appeared some papers where groups of risk have been stratified for the severe course and for the lethal outcome. This is a small paper on a small number of patients, but it shows the risk factors of severe and fatal COVID in IBD patients. It's age over 65, comorbidity, and the lack of control over the disease per se. We have already heard a brilliant lecture on the syndrome of increased epithelial permeability in COVID-19. And in COVID-19, we know that SARS-CoV-2 promotes the increase of intestinal permeability. And in case of COVID-19, we see sometimes direct damage of epithelium. We see the syndrome of systemic inflammatory response. We see epithelial ischemia. So we're looking for agents that could be an effective instrument to reduce the syndrome of increased epithelial permeability And here I show you a number of papers that discuss the efficacy of rebamipid and its effect on the syndrome of elevated epithelial permeability. So it shows the general effect and the targeted effect of this disease on separate elements. And in conclusion, I will speak about the vaccination of patients with IBD against COVID, and the experts say that vaccination of patients with IBD can be made without any limitations, and only if it is active IBD, then we discuss the issue of controlling the disease first and then vaccinating the patient. In any case, we speak about the ratio of benefit and the risk. Dear colleagues, thank you very much for your attention. Thank you that you are with us. I would like to say once again that we have a chat, and if you have questions on the presentations that have been made. And now I would like to give the floor to our next speaker. They will now we speak about intestine. We will speak about antibiotic associated diarrhea, the approaches to the diagnostics and treatment. And the presentation has been compiled by a group of doctors. You are welcome, dear colleagues. Good afternoon, dear colleagues. Thank you for an opportunity to speak. And I would like to say that the intestine is always the same, but the problems are different, including patients with inflammatory bowels disease, and they very often have antibiotic-associated diarrhea. That's why we would like to speak today about this issue, because we have been dealing in it for a long period of time. And I would like to share, I would like Sergei Tikhonov, clinical pharmacologist, to share his knowledge and his experience, because he very often had to solve the problem of what happened to the patient and how he can be helped. Plus Olga Solovyova, who doesn't only treat these patients with IBD, who have antibiotic-associated diarrhea, but Olga Ivanna has her own rich experience by treating patients with probiotic drugs. Olga, all right, Sergei Viktorovich, please present the modern state of the problem. Dear colleagues, I'd like to welcome you. Really, antibiotic-associated diarrhea is a very serious problem which we are facing, and many of our patients are living under a constant pharmacological load. Many drugs can lead to diarrhea. 70% of patients, 75% of all the complications is diarrhea. So it is a very important problem. Each fourth of drug-induced diarrhea is antibiotic-associated diarrhea. We have accumulated a lot of experience, and we can speak about pathogenetic mechanisms of diarrhea development. You see, it can it can develop through the osmotic factor, through the secretory. It can be secretory diarrhea. It can be diarrhea due to the increase of motion. So the different diarrheas are called by different drugs. So exudation is, motor activity is increased. That's why antibiotics are leaders among the drugs that lead to diarrhea. Now we look everything through the prism of COVID-19, and really at the present time we see that antibiotics are used excessively, and these are not Russian trials that say it. It is the meta-analysis of our foreign colleagues that showed that bacterial co-infection is observed in 3% of COVID patients. Secondary infection develops in 14% of cases in COVID-19. Europeans say that about 72% of patients with COVID-19 get antibiotics, and we may say that most of these patients get antibiotics not for indications, and they have a higher risk of diarrhea. Also, antibiotics, they cause not only diarrhea, but some other factors in IBD. It can be vomiting, nausea, reduction of appetite. That's why we urge to use antibiotics only in cases where they are indicated for our patients. There's a question to you, Olga Ivanovna. What is antibiotic-associated diarrhea? What kind of diagnosis? Are there any clear symptoms and factors? Of course, antibiotic associated diarrhea is very frequent, and when we see a patient, we must always ask whether he got an antibiotic therapy or not. First of all, we need to exclude antibiotic associated diarrhea, which is a non-formed stool for 2 or 3 or more days, and it is for 8 weeks after the antibacterial therapy. So what are the reasons for development of AAD? They are divided into two main parts. First of all, non-infectious causes. It's direct action on the motilin receptors by erythromycin, ceftriaxone, and we know that erythromycin was first used as a powerful promotoric, then it was used for flora effect. Then we speak about the direct damaging action on the mucus of the intestine and on the bowels, and stimulation of GIT motion. And the second group is infectious reasons, and the gravest is diarrhea associated with the growth of Clostridium difficile. Clostridia difficile was found to be the reason for diarrhea many years ago, and a lot of materials have already been collected. And some of our American and English colleagues say that the Clostridian infection leads to more lethal cases than those caused by Staphylococcus aureus. The main factors of pathogenesis are toxins, toxin A, toxin B, that are very powerful toxins and binary toxin that can produce ribotype of Clostridia difficile that is characterized by a powerful toxic action on the bowels and leads to frequent relapses. So we can see this way when Clostridia difficile gets into the stomach, in hospitalization, in contact with the affected people, with the patients who get antibiotics, and the patients with IBD. So the spores get into the small intestine where they turn into vegetative forms and then go to the mucus of the stomach, and it has its damaging effect. Also, there are very interesting facts. These are data that were received by our American and European colleagues in the epoch of COVID-19, when we use antibiotic therapy very widely, sometimes for no reason. We should we are supposed to see the growth of Clostridia difficile, but you see, this is not the case. We see the reduction of the incidence of Clostridia difficile due to the fact that very tough sanitary epidemiological measures were taken to prevent COVID and Clostridia difficile. Clostridia difficile associated damage of the bowel can be asymptomatic. So it may be diarrhea without colitis, colitis without pseudomembranous colitis, and fulminant colitis that goes with very conspicuous symptoms and very often leads to the death of the patient. When we have diagnosed that the patient, we have supposed that the patient has a higher risk of Clostridia infection, for any reason at any point, if he has diarrhea, we are to confirm our guess. And for this purpose, we have an algorithm of CDI infection, of CDI diagnostics. So first of all, we isolate the patients, we make a test of the stool sample. If the results are negative, then we are sure that there is no CDI in the patient. If it is a positive test, we are to confirm that this is Clostridia toxigenous, so it can produce toxins A and B, and then we define toxins in the stool. We can also make a PCR reaction. If we have a positive result, we know that we diagnose Clostridia difficile, and we need to treat the patient and to prescribe measures against CDI. Okay, Sergey Viktorovich. So to keep up with the time, I will shortly speak about the therapy of CDI. So some episode is determined, and the severity of the episode. The last recommendations of European and American colleagues say that vancomycin is a starting drug, and metronidazole can be used only in case of the growth of the infection. And soon it will appear on our market. If the patient has a recurrence, then we have more serious schemes of therapy. It can be vancomycin is given for 8 weeks. If vancomycin was not used for the start, then if vancomycin was used, then we can include fidaxomicin. Today, we are discussing very active about the fecal transplantation. And so you see articles that support this approach. Some articles don't support it. In 2019, in the same magazine, the same journal, there were two articles on fecal transplantation. One was for, and the other was against. But at the present time, meta-analysis say that this approach is effective. And in 2020, the GATT journal, which publishes guidelines how to treat patients, he wrote about the fecal microbiota transplantation during the COVID-19 pandemic. And the American guidelines also say that fecal transplantation can be conducted for many patients, those who are resistant to standard therapy, where we cannot achieve the result with the standard drugs. And these are patients with the recurring CDI that do not respond to other pharmacological interventions. It is not always that problems of diarrhea are a result of CDI recurrences. And I would like Olga to speak more about it. Of course, not all diarrhea that happens after CDI is a result of the recurrence of CDI. And very often we see patients who developed post-infectional IBD after a CDI infection. Almost all patients after CDI become post-infectional patients with IBD. There are predictors for IBD appearance in such patients, and we know that functional disorders of bowels are always associated with the inflammatory diseases of the mucus of the upper tract of the colon and rectum, but these are low-grade inflammations. They are developing in the conditions of increased epithelial permeability, and this low-grade inflammation will be supported by intestinal microflora that develop after the antibiotic therapy. How can we how can improve proteins and syndrome of epithelial permeability? One of the drugs that can help us solve this problem is rebamipid, that is an inductor of the synthesis of prostaglandins, and its protective qualities, its effect on the permeability of the mucus can be exploited and can be used for patients with post-infectious IBD and in inflammatory diseases of the bowels. So we are using Rebamid for patients with diarrhea syndrome who went through the COVID infection. And the first results that we have obtained allow us to conclude that this drug will be successfully used for patients with IBD, with organic and functional diseases, not only bowels, but the upper parts of GIT. We would like to remind you once again, dear colleagues, the rational use of antimicrobial drugs is the basis for the prevention of antibiotic associated diarrhea and IBD in general. Dear colleagues, let us continue. I don't see any questions in the chat. I would like to ask a question, but I hope that we will have at least 3 minutes for our discussion. Please, I would I would ask all our speakers to keep up with the time. The next presentation will be made about microbiota of the bowels. Do we know everything about the pathogenesis of GIT disorders? The speakers will be Dr. Avalueva and Stanislav Sitkin. Good afternoon, dear colleagues. Continuing the previous theme, we would like to say a few words about the microbiota of the bowels. Microflora is considered to be a vitally important component of our organism. It is stabilized and preserves its main composition. If we look at the microbiota that is presented in all biotypes of GIT and pulmonary system, skin, urogenital tract, we will see that it has a very important, it is very important for our health. Its composition may change, but it preserves its initial physiological qualities. Microbiota of the colon is represented mainly by bacteria. But as to the microbiota of the bowels in mice is very close to that of the humans, and that makes all the trials that are done today are very translatable. If we look at the functions of the intestinal microbiota, we will see it is not only differentiation of intestinal morphology, immune function, digestive function. No, it affects all the spheres of our metabolism and our homeostasis. And immune and metabolic homeostasis is considered to be the most important function of microbiota. Microbiota can also function as an endocrine organ and produce serotonin, dopamine, and others, and may control the performance of the central nervous system. That's why it is very important to understand how our microbiota is organized. So MetaHit project some years ago showed that the dominating clusters are 57, and these genomes were represented by bacteria, virus, eukaryotes, and archaea. If we look at the bacteria, we see that the main representatives lentisferas, tenericuts, spirochetas. They are not very numerous and they are very similar in humans and in animals. As to archaeovirus and eukaryotes, not very much was known, but since new methods of research were introduced, this knowledge is becoming more and more profound. Human microbiota changes with age, and the most vulnerable microbiota is in infants and in elderly people. Microbiota is individual, and that allowed the very famous microbiologist to say that microbiota has a surprising degree of specificity for each individuum. That is very shortly about what microbiota means for our organism and what is important. Over 100 diseases have been considered due to the change of the microbiota. The aberrant profiles of microbiota were found in IBD, in IBS, in colorectal cancer. And helicobacteriosis. These are the diseases that say that microbiota is very important. Recent data show that the effect of intestinal microorganisms may be more important in progressing the human diseases than we thought before. In 2019, it was confirmed that the conceptualization of approaches of systemic biology to the health of the GIT and risk management defines the interaction between microbiota of the bowel and the effect of intestinal symbionts on various levels of biological organizations. Genome of the host, gastrointestinal functional intestinal microbiota are all interconnected. The change of the microbiota composition leads to the change of its functions and to the development of metabolic dysbiosis, which is recognized by all world scientists. If we look at the dysbiosis, we see that the ratio of microorganisms is a very special, site. Here we see in different diseases, different ratios of bacteria. And in states that are associated with other pathologies, also show the reduction of obligating microflora. Of course, we have accumulated a lot of data, but for the last 5 days, the introduction of genome sequencing allowed us to study microbiota to the full extent. If we look the interaction between the host and microbiome, we'll see that the immune system of the host maintains the tolerance to various immunogenic antigens. And here you see these antigens are produced by commensals, and the response of host T cells to commensals is constant but dynamic in time. It changes in the qualitative and quantitative format depending on the state of the host health. And the immunity begins to respond here. The role of the raised intestinal permeability, we have heard a report about it today, and it is well known that at the present time that the elevated intestinal permeability is connected with the subclinical inflammation. Taxonomic dysbiosis that we see frequently today, it means the changes in commensals, and it leads to the functional dysbiosis. Metabolites are studied today, and recently there has been a large article in Lancet showing the 220 metabolites, and these metabolites our knowledge about these metabolites is still very limited. Nevertheless, the main products of metabolism are known to us. We see them in this slide. And local and systemic biological effects of microbe metabolites are studied very actively. And it shows that metabolites can be transferred through the intestinal barrier differently, and absorbed molecules can distribute locally on the mucus of the stomach. These are the metabolic effects of fat acids. synthesized by endosymbiont microflora. Here you see these acids and all these metabolites and all their effects are important for the change of the organs and systems. If we look at the state of our GIT, we see that the change of microbiota in the colon may go in three ways: when there is an infectious agent and without it. Here you see the action of here we see the microbiota of the colon in the form of biofilms. The inflammatory changes have another pathogenesis. Uh, Polygenome trials show that there is an interaction between the host microbes on different levels. First of all, the distortion of the barrier at of the barrier function, the inadequate congenital protective mechanisms, also the disorder of intestinal microflora leads to the activation of endogenous microflora, to the direct suppression of symbiont microflora, to immunotropic effect, to the sensibilizing effect, epitheliotropic effect. And at the present time, in IBD, they think that the interaction between the host and microbiome connected by genetic changes that observed in this patient and interaction of microbiota. But at the present time, this mechanism has not been studied. So if we speak about the peculiarities that are found in the intestinal microbiome in RBD, well, we may say that there is a reduced number of Clostridium, Xiva, and 4, and the increase of proteobacteria. And there is an interaction of bacteriome and virome. As to the Clostridia, you will see that these are productions of short chain acids, and the level in healthy and sick patients is different. Speaking about colorectal cancer, it is postulated that microbiota is connected with cancerogenesis with Helicobacter and herpes viruses. Again, we see a triangle. We see that microbiome, immune system, epithelial cells are very closely interconnected. Can microbes block the development of colorectal cancer? We don't know yet. Here we see a very famous axial intestine brain, and you see how they are connected with each other. And this scheme, it is a circle, it is an axle. It is not clear what is primary and what is secondary. It is banal, but whether it is a hen or whether it is an egg. Here you see the increase of many clusters, the reduction of others, the increase of such clusters as diarrhea, Amenacoccus, reduction of bifida bacteria. Look at the changes that take place in patients, how the what is to be done And remembering Dr. Mechnikov that our organism depends on what we eat and how we eat, we should think how to find a means with the minimal effect on microbiota. It is, of course, a curative correction and prevention of microbiocenosis of the bowels. And the means that are used, that we can use now, have their evidence base, but we are only in the middle of the way. If you look at the therapy, we will see that there are very few proven drugs. And we'll see that many drugs show their very high activity when they're used for inflammatory diseases, Helicobacter pylori, for IBD, and for cancerogenesis. There are papers they show it, but cancerogenosis is the theme that is outside the context of my presentation, because cancer develops for a long time, and how microbiota changes and at what stage we need correction. But there have been papers related to this theme, and we see that the quality of life is improving if patients get chemotherapy. Speaking Mark Street Congress about probiotics, we will see that probiotics are quite effective. I will say in conclusion several words about the trial of efficacy of combiotic on the basis of GABA, and we see that it is all very well correlated with the prescription of the drug. And speaking about the COVID-19 situation, at the present time, it is shown that patients with resistant diarrhea that develops in the process of this disease can be corrected. And this is a correction by drugs. They do not have any direct effect on other microorganisms. And it is provided for especially severe forms of COVID-19. The quality of life in this case is improves and diarrhea reduces. I would like to make a I would like to say, finish on the 27th June of 2021 was announced that the day of microbiota. Please, this is a European sign. Join this sign to know more about microbiome and microbiota. So we don't have much time. Brilliant presentation, very fundamental. And we have one more presentation before we start our discussion. It is devoted to the liver pathology in coronavirus. Dear colleagues, thank you very much for the invitation to take part in this very interesting conference. To speak about pathology of liver against new coronavirus infection. You know, liver lesions are different here. First of all, it is a direct cytopathic action of virus SARS-CoV-2 on the liver. But the increase of expression of ACE2 in cholangiocytes is in 60% of cells. And this expression is very insignificant in hepatocytes. There are also suggestions that apart from this receptor, there are some other receptors receptors. This problem is actively studied in order to how virus gets into the liver cells. Second is the liver lesion in case of cytokine storm. Then the development of hypoxic hepatitis because of thrombosis, microthrombosis that are associated with the coronavirus infection. Then, one of the mechanisms, especially in patients with severe cause of COVID, that is cardiomyopathy and heart dysfunction. And a special place is taken in by drug-induced liver lesion since we use drugs with the potential hepatotoxic effects. Patients with COVID-19 get required drugs very often, but sometimes they get drugs that are not needed by them. Sometimes patients also use a lot of biologically active additive drugs. And there can be also a reactivation of chronic diseases of the liver in 11% of patients. Speaking about pathomorphological changes of liver in COVID-19, this is the data limited, but that's what we have. These patients have sinusoidal dilatation. They have the moderate lobe and portal activity. They have a lesion necrosis. They have moderate microvesicular steatosis, channel cholestasis, and these changes can be caused by SARS-CoV-2 infection, or they can be drug-induced liver lesion. So virus inclusions of SARS-CoV-2 were not observed, and of course, further trials are required. Speaking about markers for the liver lesions in COVID-19, 53% with COVID-19 uh, have increased ALT, EAST. 521% have increased bilirubin. LDG is increased much rarer than cytolysis markers. And LDG may speak about the drug-induced liver lesions. The reduction of albumin level and thrombocytes is associated with the severe course of COVID-19. We should also note that patients with coronavirus infection have IST higher than ALT. So I think this is due to the effect of other than liver effects. Thus, ALT-AST increase in these patients is minimal or moderate. It has a transient character and can be considered as a prognostic marker of the course and outcome of the new coronavirus infection. There have been very many publications. I will speak about one. Almost 6,000 hospitalized patients with COVID-19 and AST increased was really associated with the poor prognosis in case of COVID. One more meta-analysis, it shows that patients with COVID and increase of ALT-AST had a higher risk of lethal outcome. On the basis of our university, we 3 times open a center for coronavirus patients, and our employees made through sampling of patients hospitalized in May and June in 2020, and examining these patients, they tested different laboratory parameters to find predictors of the unfavorable outcome of COVID. And by this data, ALT and ST were laboratory indicators for the unfavorable COVID outcome. Thus, cytolysis is usually minimal or moderate. It can be considered as the prognostic marker, but cytolysis has a transient character, and if the patient has higher LTST for a long time, it must speak about drug-associated, drug-induced, or about activation of chronic diseases of liver. So we have temporary guidelines for GIT diseases in COVID pandemic, and there are risks, they speak about risks of unfavorable outcome in patients with liver diseases. And the group of higher risk of negative outcome is patients with autoimmune hepatitis, patients with decompensated cirrhosis, patients on the waiting list for transplantation, and patients after liver transplantation. The group of moderate risk is patients with compensated cirrhosis and patients with the non-alcoholic fat liver disease. Well, and these recommendations give algorithms for the therapy and prevention of different chronic liver diseases in the conditions of COVID pandemic. There is a root of these patients in our modern reality. I would like to draw your attention to the fact that there are international registers for liver patients in the COVID situation, and they are updated, and the last update included 1,790 patients and 293 deaths, and 759 patients with cirrhosis, and 269 liver transplant recipients. And the mortality here is higher than in the population. And chronic these patients, of course, are a risk group. And drug-induced liver diseases that are developed in patients after or against coronavirus infection, because therapy in many cases is excessive and is not always adequate. What is drug-induced liver diseases? This is the morphological and functional changes of the liver tissue caused by the use of drugs. And first is the direct hepatotoxic lesion can develop depending on the dose. It can develop in any individuum. And the second group is idiosyncratic lesion. Which we can see in patients who have their special organic peculiarities. It doesn't depend on the dose. It is observed in separate individuals. And speaking about the drug-induced liver lesion, this is a diagnosis of exclusion and requires a lot of tests to differentiate it with other diseases. First of all, we should use RUCAM-SIOMS scale, And when we have liver lesions, we need to determine the dominating type of lesion, hepatocellular, cholestatic, and the mixed type, because it is important for the further treatment and management of the patient. And to assess the hepatotoxicity of the drug, we may find on the site liver tox. Over 1,000 drugs have been registered there. This site provides information about drugs that are used for coronavirus infection. There is also the drug bank about drug interaction. We can also see the interaction of drugs that we are prescribing, especially if we are prescribing many drugs. Also, there is a separate site about the assessment of drugs used for COVID-19. These are examples of 3 antibiotics that are most often used for this group of patients: amoxicillin clavulanate, azithromycin, and levofloxacin. All these drugs cause different lesions of liver, and all these drugs are referred to class A of hepatotoxicity. And these antibacterial drugs are prescribed one after one or sometimes together in the combined antibacterial therapy, which is not needed for the patient. Plus, the patient gets antiviral drugs, anticoagulant drugs. Recently, we have seen such a patient. That's why when we prescribe the drug, we need to assess hepatotoxicity and drug interaction. So, and the basis for treating this disease is to discontinue the drug that induced the liver lesion. In severe cases, we also prescribe glucocorticosteroids and ursafalk in the dose of 13-15 milligrams per kilogram of weight. As the ursoxycholic acid has, ursafalk has a wide mechanism of action, immunomodulating, anti-inflammatory, anti-apoptotic, and thanks to these effects, immunomodulating, anti-inflammatory, anti-fibrotic, cytoprotective, anti-apoptotic, shows that it may be used not only during the COVID-19, not only for the liver patients, but in general for the treatment of COVID patients. Also, ursodeoxycholic acid attenuates hepatotoxicity of multi-drug treatment of mycobacterial infection. Why ursafalk? Ursafalk is a reference drug which showed the high efficacy in treating liver pathologies, and it is part of the reimbursement list. In COVID-19, the mechanisms of liver lesions are various. Markers of the lesions are minimal or moderately expressed and have a transitory character. They can be considered as prognostic markers for the course and outcome of the new coronavirus infection. But if after the coronavirus infection, the patients have these markers, it is very likely that it is drug-induced liver lesion or inactivation of the chronic disease. So we have 5 minutes. I would like to thank the speakers, and we have 5 minutes for communicating with the audience. Probably you saw the question in the chat. Let me ask you. In post-COVID period, the syndrome of diarrhea, severe diarrhea, we have very, very little time, remember. Do you have any recipes for this case? Let me start. If it is severe diarrhea, first of all, we need to understand what it is caused by, whether the patient get antibiotic therapy. If first of all, we need to exclude the Ostridial infection, antibiotic-associated infection. And as to the lesions of the bowels, we need to verify the genesis of this diarrhea syndrome. In the context of diagnostics, toxin Y, I, and B, there are situations when there are only one of the toxin is positive, the other is negative, and how we're supposed to treat it. It's not a simple question. If we define toxin, at least one toxin, A or B, I would prefer to consider this diarrhea as Clostridia associated if there is a positive test that shows a Clostridial infection. Okay, can we sum it up? A or B is positive. Is it pseudo positive or pseudo negative? I would ask for a help of a friend. Of course, we come across such things. So a small deviation. The algorithm that was demonstrated by Olga Ivanovna is a Western algorithm. They have a two-step approach. When you first define the presence of Clostridia by PCR or by any other test, and then we confirm toxicity of Clostridia. That's how they work in the West. In our routine practice, at least in most of our hospitals, we use tests to define toxicity A and B, and if there is toxin A or toxin B or combination, we speak about Clostridial infection. As to this two-step approach, it is more economical and it is more precise. This combination increases specificity and sensitivity. We don't have it. That's why in clinical practice, if there is diarrhea, if there is toxin A or B, we can start anti-clostridial therapy. I hope our participants received a reply. There is a question about alpha normics or rifaximin alpha. Is there any sense in prescribing alpha normics in such states? Of course, I think the question is about post-COVID situation. Are there any opinions or ideas? Rifaximin alpha can be required in some situations, speaking especially about Clostridial infection. Yes, in America, it is a drug to treat relapses of Clostridial infection. That's why if it is post-Clostridial syndrome, that Rebagit can be used and alpha normics can be used. As to the evidence, serious evidence evidence base for the use of alpha normex in post-COVID syndrome, there is none. But I know the mechanism of action of this drug. We use it actively. It can be used. I will add that the drug has any biotic action. It creates the maximum inhibiting concentration for gram plus and gram minus bacteria. That's why it can be considered quite seriously, especially for the prevention of this translocation in the conditions of the syndrome of elevated epithelium permissibility, and for what period is to be prescribed Rebagit. I think there haven't been yet papers about it because the drug in Europe hasn't been registered. If we prescribe it, we proceed from the instruction, not more than 8 weeks. On the other hand, we know that this drug is a universal mechanism of action for the syndrome of increased epithelial permeability because the drug can be prescribed for atrophic gastritis for a longer period. That's why we think this is a drug of the pathogenetic row. It can be prescribed for 8 weeks and more, depending on the clinical picture. And of course, as a drug for complex treatment after the verification of the diagnosis, and after what period can we vaccinate patients with IBD after the COVID infection. No, it is a re-vaccination, I think. Yeah, we can say that the patients with IBD, like other patients from the general population, the same rule, 6 months after the COVID infection. And also the about Rebagit in IBD. Can we prescribe Rebagit or Rebamipid for IBD? Do you have any comments? So the evidence base is very weak, but we prescribe and there are no counterindications, and it has a positive effect. Sergey Viktorovich, I agree. In accordance with the instruction, we cannot prescribe it, but there are papers from Japan. In Russia, we are making trials on safety and efficacy of this drug. In the future, now, in accordance with the instruction, only if there are some comorbidities, ulcer disease. Yes, of course, together with the basic therapy. So, remembering the first presentation of Professor Mayev, if there is IBD, if there is a syndrome of increased epithelial permeability, it is one of the links of the pathogenesis. That's why the drug could theoretically be prescribed. But in order to prescribe it in accordance with the evidence base, we need to have more trials, and let us have a look at these trials and wait until they are included into the guidelines. Well, dear colleagues, I would like to thank all the speakers to say that we have been together at the symposium devoted to the pathology of GIT. But we are at the Eurasian Congress of Internal Medicine, and those who moderated the program know that we are ours were a very powerful part in the Congress, and I hope you will welcome all our symposia, will be active participants of this process. Thank you very much. I hope to see you soon. Goodbye.